I'm very excited to see how that flex, the happy 10-year into a flex. It's going to be really good to see how that comes together. So for this next session, I'm really excited to reintroduce Dr. Casper. Obviously, you guys got to hear from him during the last Q&A session, but Dr. Casper has really been a key leader in the Castleman's field for many, many years. And I'll just share just the quick anecdote that when Corey first came to our first meeting, that was the first meeting we ever had. It was in 2012 in Atlanta. And I remember we organized this meeting and I wasn't sure who was going to show up. Was it just going to be basically, me in a room by myself? And which I was pretty sure that's what was going to happen. But Corey was one of the first people to come into that room. And I remember how it all of a sudden made this feel like real and made it feel like maybe we really are going to be able to get all these people together. Because I had read Corey's research studies and his papers, and I hadn't met him before, but all of a sudden it was sort of like in the flesh, seeing someone who I knew had been thinking about Castleman's for years and was a real leader. And that was a real turning point. It was like, okay, maybe we really can do this thing. So really, really honored to introduce Corey, and he's going to be talking about COVID and Castleman disease, the interaction between the two, and of course, things that you guys should be thinking about. So thank you so much, Corey.
Thank you, David. Yeah, it's okay. Thank you. Appreciate it. Probably one of the first times that I've been told that I walk into a room and something good happened, as opposed to walking in the room and sort of deflating the mood. But yeah, and I feel the same way about David. I mean, it's so inspirational and everything that he's done to get us all together and talk about this important disease. So it's great to see everyone here. I know that for the past 2.5 years, we've been talking about nothing but COVID, and we're probably pretty sick of talking about it. But we're all still here 2.5 years in, wearing masks. I took mine off just to give the talk, but so it does seem like a topic we should address today. And if I leave you with nothing else, hopefully it's with a glimmer of hope that things will get better and you will be able to take these masks off soon, and we'll get beyond this. So what I thought I'd talk about today, I don't know if I just, there we go. Great, fantastic. So what I thought I would talk a little bit about today is the relationship between Castleman's disease and COVID. And probably I don't have that much to say about that. I can summarize it by saying we don't know a whole lot, but I'll tell you what we do know. But more importantly, I thought what I would do is talk a little bit about what the future of preventing COVID might look like for all of us, so that we can stop discussing this maybe by the time we have this meeting next year. So what I thought I would talk a little bit about is, let's start by talking about the virus. And so we'll talk about the virus that causes COVID, which is SARS-CoV-2. Again, everyone's really become an expert on this now, but just to make sure we're all on the same page. What we'll talk about is the immune response that your body has against SARS-CoV-2 and how that is, as we mentioned earlier, similar in many ways to the immune response that your body has to Castleman's disease. Then what we'll talk about is COVID different, more severe, less severe, same severity in patients with Castleman's disease compared with other patients or other people in the world? And then finally, we'll talk a little bit about what we can do to prevent COVID in patients with Castleman's disease. So we'll talk about the two modalities we really have right now, which are vaccines and antibodies. And lastly, we'll talk about where we are with treatments of SARS-CoV-2. So we have about 20 minutes, I think, maybe. I know we're running a little bit over and I want to make sure we keep to time. I'm always happy to answer questions. My email address is the least kept secret on the internet, so feel free to email me if you have questions or anything else you need. So let's start by talking about the virus itself. So we all know by now that this is in a family of viruses, and it's actually viruses that we've known about for quite a long time. So in my career, I've spent a long time studying how infections complicate people going through cancer care. And that's how I first got involved with Castleman's disease, because of its similarities to lymphoma. But we've been talking about coronaviruses for years. So what we know is that generally in patients who are going through cancer care, these viruses used to be a nuisance, but that they hung around for long periods of time. So very few of us who work in this field were surprised to find that these viruses are still hanging around with us now, 2.5 years into this pandemic. They get their name because they have this crown, when you look at them, a corona, under an electron microscope. And you can see that that crown consists of these things that we call the spike protein. Now, why am I going into all this? And I'm recognizing it's late in the afternoon. You may start dozing off. So why is this important? And I'm not going through this because we're at a medical school and I want you to sort of be virologists in training. I'm going through this because everything that we've been talking about when we talk about vaccines, we're talking about this spike protein. So the spike protein is what the virus shows to the outside world, and it's what it shows to your immune system. So it's where your immune system directs most of its activities, is making antibodies against that spike protein. Now, that spike protein is the basis for all of our current vaccines against COVID. The problem with that is that the virus is smart. So these viruses, estimates now suggest that you make, in the course of being infected with COVID, you make about 1 trillion viral particles. So over the course of your infection, you're making about 1 trillion of these things. And when you make anything, whether it's cookies or cars, when you make 1 trillion of them, you're bound to make a few mistakes. So what happens is that the more you make this virus, the more you begin to make mistakes. And when you make mistakes in a virus, what that means is that you make that spike protein look a little bit different. So when you make 1 trillion of these, they don't all look the same. And eventually what happens is that that spike protein looks so different that the vaccines that you make against it don't recognize it anymore. So on one hand, this spike protein is critical because it's sitting on the outside of the virus and it's how your immune system interfaces with it. It's an obvious target for vaccines, but it also is one of the reasons why we're still struggling with our vaccines, because as the virus either drifts or shifts, so as it makes more of itself and changes, that spike protein is the part of the virus that is most variable. So in some ways, it's not the best candidate for a vaccine, but in other ways it is. So it's a mixed bag. What would be an ideal vaccine is a vaccine that targets that protein as well as others. And the good news for you, to cut to the end if I lose you and you fall asleep, is that we now have vaccines that should be introduced in the next several months that go beyond just that spike protein. So good news coming, but all you need to understand about this virus is that it has these spikes on the outside, and it has other proteins that are on the inside and more hidden to your immune system, so less likely to change under the pressure of your immune system and can offer another target for vaccines in the future. This is a pretty complicated diagram taken from a medical literature study, but what it shows in nice detail is actually what happens when you become infected. Now, every time I use one of these pointers, I turn something off, but I'm going to try. Did that work? Yeah, it did. Okay, great. So here you can see the viral particle. It goes into it goes through your nose and your mouth down deep into your lungs. And once it's down in your lungs, it infects these cells that are at the very base of your lungs, called the alveolar epithelial cells. But it enters those cells and then begins to cause inflammation in your body. And you can see that there's a whole different types of cells that it infects and a whole series of inflammation that it sets off. But a few things I want to point out from this slide. So one is that the way it gets into a cell is through a receptor. So the way we think about viruses and cells is it's like a key in a lock. So if the virus is a key, it's looking for the lock that lets it in. And the lock that lets this key in is a receptor called ACE2. Why is that important? Well, the reason that's important is that this receptor is on almost every cell in your body. So what we're finding now is that when people are infected with COVID, the reason that they're getting long COVID is because the virus goes beyond the lungs to almost every cell in your body and actually finds a way to persist in those cells over long periods of time. So what we now know is probably up to 10% of people who get infected with SARS-CoV-2 will have what's known as long COVID. And that long COVID means that the virus remains in cells in your body, continuing to trigger your immune system and trigger inflammation. If that sounds familiar, it's because that's a very similar process to what's happening in Castleman's disease, except for the fact that the trigger is not a virus, it's something that we don't understand. So the bottom line is that COVID is doing things that is very similar to your body that Castleman's disease is. And it's one of the reasons why one of the treatments that we use for severe COVID is the same treatment we use for Castleman's disease, the interleukin-6 inhibitors. So I hope that that brings together a little bit about the similarities of this virus with your Castleman's disease. But what it also means is that there's lots of opportunities in someone where these signaling pathways are already dysregulated or abnormal because of their Castleman's disease. You add a virus to that, and that could potentially make things worse. So we talked about the virus. Now let's talk about what your immune system does. So again, a little bit more complicated of a diagram here, but I tried to make it a more simple cartoon. So what you see here is that you see that this is a cell that's infected with SARS-CoV-2. And what happens is that you have two different types of immune responses. One type of immune response is your antibodies. And your antibodies are your first line of defense. Your cells in your body called B cells make these antibodies, and these antibodies try and sop up the virus and get rid of it. On the other hand, though, they are not actually doing anything to eliminate the virus that's within cells replicating and making more of itself. So this is just scavenging for the viruses that are loose in your body. So antibodies are an important component of your response, but they're actually just controlling the disease. They're not actually getting rid of the virus. You have another arm of your immune system called your T cells. These T cells are what we call professional killers. And they go out and they find cells that are infected with viruses and they kill those cells. And when they kill those cells, it gets rid of the virus and the virus can't make any more of itself. So why am I bringing all this up? Well, for a couple of reasons. So in Castleman's disease, there is dysregulation of these B cells in a way that they're not producing antibodies in the way that a healthy person does. So it is conceivable, and again, we don't have research to support this because we just haven't done much research in patients with Castleman's and COVID, but one would suspect, and in the initial studies of Castleman's disease, we know that patients with Castleman's are at risk of infection more commonly than patients without Castleman's disease. And one of the reasons for that is because their B cells are not making antibodies as well as someone who doesn't have Castleman's disease. On the other hand, the way that your T cells are called in to fight an infection is through a series of chemicals that your body makes. Well, guess what one of the chemicals is that calls in those T cells to fight infections? Interleukin 6. So it's another reason why patients with Castleman's disease who aren't making interleukin 6 the way healthy people do could potentially be at more risk of having complications from SARS-CoV-2 than someone without Castleman's disease. I know that this is all really complex, but I'm hoping it's making sense, even though it's kind of detailed immunology. So this slide kind of summarizes that, and you can have a copy of it if you like, but really what it says is that these mechanisms that we typically use in healthy individuals to fight viruses are dysregulated in people with Castleman's disease. And so when COVID first hit, we were all very concerned that Castleman's disease would be more severe in patients with COVID would be more severe in patients with Castleman's disease. And we were very worried about that. And I remember getting a call from David saying, what should we be doing about this? So we did try and study this. And again, you may get sick of hearing this. It's kind of a common answer. With only about 5,000 to 10,000 patients with Castleman's disease in the United States, it's hard to really know what's happening with a new disease like COVID, but we've tried to look at this. And this was a study that was presented that a lot of the folks here really did the heavy lifting on. But this looked at the registry, and it was a survey that maybe some of you answered of about 300 patients who participated in the registry here. There was 124 who responded, so about half of you who got an invitation to responded. And again, when we do medical studies like this, you always have to wonder, well, are the people who are responding because they had COVID or because they're really interested in this? So it brings up all kinds of issues that we call bias. However, half of the patients responded. About 90 of those reported they had been tested for COVID, and about 17 of them had had a positive case. So all things considered, that's about 18% of patients who were asked and had been tested positive. That's higher than the general proportion of people in the United States who have tested, or at that time who had tested positive for COVID. So can you conclude from that COVID is more common in patients with Castleman's disease than in people who don't have Castleman's disease? I think that's a stretch, right? We're basing this on 90 people who voluntarily answered a survey. So hard to say, and I want to be really modest about this. What we did see was that among those who had symptoms, and we tried to break it down to unicentric disease, multicentric disease, and the viral associated disease, when we tried to say, well, are your symptoms different than the general population? Not really. It kind of looked the same. The degree of severity was about the same. The symptoms that you reported in terms of fevers or chills were about the same. So the bottom line is that we don't really have a whole lot of data. Maybe you could conclude that Castleman's disease is more common in people. COVID is more common in people with Castleman's disease. but probably not more severe. And that's based on just a limited amount of data. So take it or leave it. I don't know what to make of that. Is it because you're already on an interleukin-6 inhibitor? So maybe that prevents the virus from getting very severe, because that's exactly what we use in severe cases of COVID. Maybe. Is it because there's just no difference in your immune system and your immune system is good enough? We just don't know. But from what we could look at, from when we try and approach it this way, when we see something that's important to patients with Castleman's disease, we try and do that research. We really try and understand this is what we could find. So with that, I wish I had more, compelling data to share with you, but that's what we know. So let's talk a little bit about how you can prevent yourself from getting COVID or from getting COVID again if you've already had it. And so really what we know is that vaccines have been the mainstay of how we've prevented COVID. The estimates are that vaccines in the United States have prevented about 1 million COVID deaths. So certainly I'm not here to tell you that these vaccines are not good and not important. And were developed certainly with record speed. But at the same time, I am here to tell you that I don't think they're good enough. And so I'm a vaccine developer. I work at a nonprofit that works on vaccines. And what I can tell you is that we have a lot of work to do. So the way vaccines typically work is that these vaccines they show you a part of the virus and then allow your body to make an antibody response to that part of the virus. And as we talked about really on one of the first slides, these vaccines are focused against that spike protein. What we know is that there's different types of vaccines, and the vaccines that we've been using right now, mostly for COVID, have been RNA vaccines, which means that we take a piece of the virus, we encode for it on a piece of RNA, we introduce that RNA to the cell. Your cell then makes that protein, that part of the virus, and then your body makes an immune response against it, which is primarily based on antibodies. But there are other types of vaccines. So the vaccines that we all got as kids were protein vaccines. They just took the protein itself, they introduced that to your body, and your body makes an immune response to that. Up until recently, we haven't had any protein vaccines that are available for COVID, although there was one that was just approved by a company called Novavax. And finally, we can also introduce a protein to the human body, not just by RNA, but also by DNA. So we can make DNA turn into proteins as well. And that's the Johnson & Johnson and the AstraZeneca vaccines. So the reason I'm going through all of this with you is because I do believe that these different vaccines have different advantages and disadvantages to patients with Castleman's disease. And I'll show you those here. So the protein vaccines that we've talked about, really the only one that's available right now for patients in the United States is something called Nuvaxovid, and that's the vaccine by Novavax. The live viral vaccines, these are the DNA vaccines, and so that's the Johnson & Johnson vaccine that they call J-COVID. And then the nucleic acid vaccines are our RNA vaccines, and that's the Moderna and the Pfizer vaccines, Spikevax and Comirnaty, horrible names. But anyway, these are the different vaccines that you could potentially get. And you may ask yourself, is any one better than any other for patients with Castleman's disease? So I put together this pretty simple table, and there's pros and cons to both of them. So the RNA vaccines, what we know, and they're pretty much the same. People ask me, are they different? Is the Pfizer better than Moderna? Is Moderna better than Pfizer? Pretty much the same. But generally, they cause you to generate strong antibody responses. We know that they're safe. I mean, literally, there's been over 100 million people just in the United States who've gotten these vaccines, and we know that they're safe. They're rapidly adaptable to new strains. So you saw last week, the FDA approved a vaccine that is available now against BA4 and 5. And so those are some of the strengths. But the weaknesses is that their durability is very limited. We know that in a healthy person, these vaccines last about 3 months. Now, when I say last about 3 months, that means really strong protection against getting sick. They probably still prevent you against dying, which is good news, but they do nothing against preventing you from transmitting it to someone else. So they have limited durability. They don't invoke those killer T cells to destroy the virus in your body. And they really don't do very much in preventing transmission from one person to another. The adenovirus vaccines, the J&J and the AstraZeneca, also make good antibodies, but they also do cause you to make some of these killer T cells, and that's probably good news. The The bottom line is that they don't work that well. They're only about 75% effective versus the RNA vaccines, which are 95% effective. Early on, there were some safety concerns, and I think it's fair to say that in a very small number of people, they probably do cause problems with bleeding or clotting. The one thing that I think we haven't seen, but we're all concerned about, is that these are actually live viruses that have been what we call attenuated or had genes knocked out of them so they don't make you sick. But there is the possibility that as they replicate in your body, they can mutate and go back to something that actually could make you sick. So for that reason, with these live viral vaccines, we don't typically recommend them for people who have a compromised immune system. Now, that's usually patients with cancer or HIV. Whether that's patients with Castleman's disease, we don't know. But I'm a very strong advocate for saying that if you don't know and you have an alternative, try something else. So my advice to my patients with Castleman's disease is that they don't get these adenovirus vaccines. One, because they're not as effective, but two, because there is the very small possibility that they could mutate in the setting of a host's immune system that isn't as strong and cause problems down the line. Finally, we have these new protein vaccines, this Novavax. The benefits, they have strong antibody responses. There's a really long track record. Protein vaccines have been used for over 100 years, so we know that they're safe. Literally billions of people have gotten them. And we do think that they're probably more durable. So these vaccines, rather than lasting 3 months, will probably last a year. And that is something that I think is better if you don't want to keep getting boosted. The problem right now is that they're only authorized for a primary vaccine in the United States and that they don't have a lot of efficacy against the new variants that have emerged like Omicron. So you might look at all of this and say, well, this kind of sucks. Like there's no perfect vaccine that I can take right now. And you're right, there isn't a perfect vaccine you can take right now. So what does the future look like? Well, so last week, and I made this talk 3 weeks ago, but I predicted, not that I had a crystal ball, we all knew this, but that we would get more variant-specific vaccines. So last week, the FDA authorized the BA.4/5 boosters. Question I get all the time from friends, family, and patients is, should I take them? My answer is that yes and no. So right now, it's the best that we've got. There is no virologist that I know that thinks that these same strains will be circulating in a few months from now, and that we'll have new strains that these boosters won't be effective against. But for right now, it's the best we've got. If it's been more than a few months since you've had your last vaccine, I would recommend that you take these Omicron-specific boosters because you all, I think, might be at more risk. Certainly, even if you're a family member, you don't want to transmit that to a family or loved one with Castleman's disease. So I do think at this point, those boosters are the best that we have. We and others, when I say we, I mean my organization, but the world at large, is working on pan-coronavirus vaccines. And what I mean by that is that these vaccines will be effective no matter how the virus mutates. So the way that we're approaching that is a couple of different ways. One is that in addition to targeting the S protein, we target another protein, the N protein. So you'd have to have mutations in both of them to make the vaccine not work. And the mathematical models show that that will be very unlikely. So those vaccines are now in late phase clinical testing, scaling up for production. I don't think that they're going to be available, ours or others, for your arms until probably the beginning of 2023. But that is something I think that we will see in the near future. We also have vaccines now that have something in them called adjuvants. These are immune stimulants that make them last longer and give them protection across a wide range of coronaviruses. And again, those are working their way through the clinical testing pipeline. I hope will be available in early 2023. So the good news is better vaccines that are lasting years, not just months, are coming. And I think they will target a broader range of viruses. The problem right now is that there's we've lost steam. So really, many people are fatigued about COVID. They don't want to hear about vaccines. And so how quickly these will progress through the regulatory framework in the United States is not clear either. But I do think there's hope that better vaccines are coming. So this basically just summarizes what I said. And another question I get a lot, should you mix and match? I would say, bottom line to that is that yes, mixing and matching will lead to stronger immune responses, but right now your choices of mixing and matching are kind of crummy, so there's no point. But in an ideal world, mixing and matching would work. But right now, I wouldn't do it. Whatever you started with, I'd keep getting. I'll talk about two things quickly because I know my time is limited. So I want to talk about monoclonal antibodies and then treatment. So for monoclonal antibodies, there's two different approaches. There's one monoclonal antibody called Evishield, and that's recommended for the prevention of COVID. And there's another monoclonal antibody that we'll talk about that's used for treatment. These aren't bad. So right now they continue to show efficacy even against the Omicron variant, and they're very effective. So we use them all the time in our patients who are unlikely to respond to vaccines. And that's patients who are undergoing what we call cytoreductive chemotherapy. That's in patients who are receiving transplant either right before or right after. And that's patients who are on high-dose steroids. And I know that a lot of clinicians manage Castleman's disease sometimes with bursts of high-dose steroids. So if that's something that your clinicians are doing, this is something you might want to think about. It provides you probably about 3 to 6 months of protection, less protection against Omicron, but still good. So what I would say is that most Castleman's patients probably don't need Evishield. However, if you meet one of these criteria, I think it would be important for you to have this, and it does provide protection. Lastly, we'll talk a little bit about treatment. And so for treatment, really first thing I want to say is take a deep breath. So even in Castleman's disease, the overwhelming majority of patients who get COVID will resolve it. Now, there are people who are at higher risk. That's people who aren't vaccinated and people who are immunocompromised. So where Castleman's disease fits in on that, we don't know. But at least in these 90 patients that we studied, it doesn't seem as if this is something that should make you panic. However, what we know is that patients with Castleman's disease may be at higher risk, and that what we know is that we do have different ways of treating this. So right now, the landscape looks like this. We have antivirals and we have monoclonal antibodies. So for patients, the way we think about treatment is how severe your disease is. If you have mild to moderate COVID disease and you're an outpatient, right now, the thing that most people are reaching for is Paxlovid. It's an oral antiviral drug. It's mostly effective, although what we're seeing is about 20 to 30% of people, the president and the first lady included, have what are called rebound. So they will have their disease recur after just 5 days of treatment. Many providers now are extending treatment just in everyone to 10 days, but it is very effective. It does have a lot of drug-drug interactions. So if you're taking siltuximab is not one of them, but if you're taking other drugs, it is important to recognize that there are those interactions. The other thing that is used for mild to moderate disease as outpatients is a monoclonal antibody. It's got a terrible name, Telemab. It is effective, but it is less effective against Omicron, but it's out there for patients who have too many drug-drug interactions to take the Paxlovid. For moderate disease, and that means essentially that you've been hospitalized, the typical antiviral that we use is an intravenous one, not an oral one. It's called remdesivir, and it's been shown to significantly reduce your risk of dying if you've been hospitalized with COVID. And finally, if you also have severe disease in an inpatient, we do give remdesivir oftentimes with other immune modulating therapies like interleukin-6 inhibitors, but the landscape of treatment has really changed. And what I'll tell you is that I still take care of patients with COVID. The difference from the beginning of the pandemic to now is dramatic, and the death rates from COVID among hospitalized patients has dropped close to 80%. So we're getting much better at treating this disease, but it remains something right now that's common and morbid. So with all of that, here's my summary. That again, we're still seeing a ton of SARS-CoV-2 across the world, and it's not likely to go away anytime soon. It's magical thinking to think it will. That patients with Castleman's disease could be at higher risk, but so far, at least the data that we've seen have not shown that. That the vaccines are very effective in preventing you from dying and from getting severe disease. They're not that good from getting you moderately sick or from preventing you from transmitting this to others. That for patients with Castleman's disease, I strongly believe, and I have no conflicts of interest, that RNA vaccines are the safest and most effective, but that will require at least 3 doses and boosting, I would say, at the very minimum every 4 months. I do think we'll see new vaccines in 2023, fingers crossed, and that these may last longer and prevent new variants of concern. For patients who are immunocompromised, getting the monoclonal antibodies is a good way of preventing this if the vaccines aren't safe for you. And finally, we do have new approaches to treating COVID, so it shouldn't be something that you fear as much as before. This can be a disease that we can treat relatively easily. So with that, I'll stop, ask if there are any questions, and I appreciate all of your time. Any thoughts or questions I can answer? Okay.
So when we get the vaccine, we produce antibodies. Somebody who has Castleman's disease, their immune system is already compromised. Now, I know they tested her and she produced antibodies, but is that for all Castleman patients, or do some Castleman patients do not produce antibodies?
Yeah, great question. And I'll repeat it just in case people didn't hear it. So the question is, do Castleman's patients make antibodies when they get vaccinated against COVID? So I wish the answer was as simple as a yes or no. The answer is most do, and most make a good number of them. The question is, not all antibodies are the same. Some are really good and some are really bad. So what we really want are what we call these broadly neutralizing antibodies. And I think, again, I wish I had more data to support this, but in Castleman's patients, your B cells, which are the cells that make the antibodies, are distracted. They're making lots of antibodies against other things. And so they can't make the quality of antibody that is as good as someone else's. So when you measure them on a test, and those tests are not notoriously accurate unless you get them from like the government, but those, if you measure those, it may tell you have enough antibodies. So you may have enough quantity, but the quality may not be the same as someone who doesn't have Castleman's disease.
Okay.
Does that make sense?
Kind of.
You'll make the antibodies. They will be mostly protective, but they're not as good as someone who makes. So if you have a level of 500 and I have a level of 500 and you have Castleman's disease and I don't, my antibodies are probably better than yours. So it's like, having 500 pieces of gold versus 500 pieces of copper. We both have metals, but they may not be as good.
Oh, okay.
Yeah.
Okay. So my other question is, this came from a family member, but she was telling me that when you get a vaccine, it targets your T cells. And she goes that it alters your cells or something, like forever. I mean,
yeah. So again, your question is, a family member told you that when you get these vaccines, they may alter your cells forever. Is that?
Yeah, because she mentioned the T cells.
Yeah. So a couple of ways to answer that question. So first of all, the RNA, when it goes into your cell, right, those cells that it goes into only live for about a week or two. So even if it were to alter those cells forever, they're dead and gone a week later. So one, I'm not too concerned about the vaccines altering your DNA or altering your, causing these, horrible side effects in you that are going to be long-term, because the cells that they go into leave. Now, what they do is that they cause a memory. They cause your B cells and your T cells to remember to make a response against these proteins. That happens every day. So every day you come in contact with a bacteria or a virus, that's the job of these T cells and B cells. So long answer is that I don't think that you're going to see any long-term complications from these vaccines, like risks of cancer or risks of autoimmune disease. I think we know that they're safe. They've been given to so many people right now, and we're just not seeing any of these problems. So I think that they're safe. I'm not worried about that. I just wish they were more effective and more durable.
All right, thank you.
Yeah, sure. Other questions? Yeah.
Do you think the study of COVID is going to impact the treatment of Castleman's in any way?
That's a great question.
In what way?
Yeah, so will the study of COVID impact Castleman's? I would say yes, potentially, in two different ways. So, again, this is kind of a generic answer, but if we think about how we used to treat autoimmune diseases or even cancers, when we wanted to calm down the immune system, we used to basically hit it with an atomic bomb, either chemotherapy or high doses of steroids. That pretty much shuts down your entire immune system. But your immune system has lots of different arms to it, right? And what you really want to do is only shut down the part of the immune system that's causing you problems. So if you think about Castleman's disease, 40 years ago, mainstay of treatment, high-dose steroids caused broad dysregulation of your immune system, not a good thing. Now we give a very targeted medication, whether it's rituximab, which just works on one type of cell, or siltuximab, which just works on one particular cytokine. So we're getting much more specific about how we tune up and tune down the immune system. What COVID is teaching us is how all of these different medications broadly tune up and tune down the immune system. And because Castleman's disease is so rare, we don't have a large number of people to study it in. But by looking at patients with COVID, we really know what happened. We've given interleukin-6 inhibitors to, I would say, orders of magnitude more patients with COVID than we have with Castleman's disease. So what we really are going to know, all of these questions that you're asking us about how safe are these interleukin-6 drugs, what are the long-term side effects, literally now, hundreds of thousands of people have gotten them for Castleman's for COVID, so we'll know more about that. So COVID will teach us more about the safety and exactly how these drugs tune up and tune down the immune system, and hopefully that will translate to us being able to use them with more confidence and more precision in patients with Castleman's disease. The other thing I would say, just in terms of what one may teach us about the other, is that I think that what we are learning now is that there are long-term ramifications of getting infected with SARS-CoV-2 in terms of what it does to your immune system. And I think that what we may find is that it is possible that we'll find that some of the things that we see in patients with long-term COVID may start to look a lot like Castleman's disease. And if we start to see those similarities, we can explore the biology of what is similar, and that may help us understand what causes Castleman's disease.
Will it affect the treatment protocols? Maybe some of the treatments discovered for long haul COVID patients become Castleman's treatments?
That's my hope.
Because of the funding?
Yeah, that's my hope. And so I'll give you one very concrete example. So what I think is one of the most promising treatments of long COVID right now are something called NK cell therapy. So this is essentially giving patients a type of killer immune cell that seeks out the virus that is remaining in cells and destroys them. What we now know is that when you give these to small numbers of patients with long COVID, their symptoms resolve. So the question is can these NK cell therapies have also been very useful in a number of different cancers like lymphomas. And so the question that I think you begin to ask yourself is, could you potentially treat Castleman's disease with these NK cell therapies? And I think the answer that we may learn is yes, maybe. And so again, that area of research, I think we can bring to Castleman's disease and lead to better therapies in the future.
Unfortunately, I think we're out of time now, but thank you very much, Dr. Casper.
Thank you all for your time.